let's start with Regeneron 5458, which of course I would know what that is. But this is just to be clear. So is a phase one update? It's an early update, or is it farther along? Okay.
It's in a phase one because we thought we had the perfect dose, and it looks like you can actually push the dose a little more. And this is a really good point that it's a little complicated to figure out dosing for these new immune drugs. Old school chemo drugs, the response curve tends to be linear. As you give more drug, you may get more efficacy, but you get more toxicity. But activating the immune system doesn't necessarily work that way. So sometimes you hit plateaus or it curves up. But we have probably figured out where our dose is going to be for the phase two study. This is a BCMA CD3 bispecific. The drug is extremely efficacious. Um, when we give it at the higher doses, we see response rates of over 60 to 70%, and not a whole lot of side effects. The big side effects we worry about are pretty much the same between bispecifics and CAR Ts. We're activating the immune system. So if you overactivate it, you can get something called CRS, cytokine release syndrome. And we do see that, but really not high rates for 5458, mostly grade 1, grade 2, which means it was pretty mild. So it's a very well tolerated drug, highly efficacious in patients who've had 5 or 6 prior lines of therapy. And we're really hoping to get this in the clinic as soon as possible.
Oh, that's very promising. Again, yeah, people who may be quote running out of options or been through so many different lines and are looking for something new. To be clear, how is this administered when we talk about bispecifics? I don't know if there's a range, and also it looked like in the study more like a higher dose seemed to be better or something like that.
The whenever we do early phase trials, we usually use something called a 3 by 3 design. You give 3 patients 1 dose of a drug, and as long as they don't have major side effects, you go up a dose level, treat 3. And if anyone has any issues, you expand out and treat more patients, and you do that until you find the right dose. And so some of the patients who got the low doses did okay, but as we got to higher doses, 50 milligrams, 100, 200, people started to do even better. Right now, this drug is administered as an intravenous drug, and the majority of our bispecific antibodies are. However, in the last year, we've started to develop a number of these bispecifics as subcutaneous injections. So that's really in the works for a lot of these products, either already in clinical trial or going to start in clinical trial in 2022.
That's so great. And as a single agent, that response is really something else, right?
It's so to put it into context, if you look at our last couple approvals in myeloma, drugs like melflufen, drugs like Blenrep, drugs like selinexor, in patients who are triple class refractory, we saw overall response rates of around 20 to 30%. Now, with a single agent in a more heavily pretreated group of patients, all the bispecifics are between 60 and 80% as single agents. Once we start combining them and moving them further up, there's no telling how good the outcomes could be.
Wow, that's really exciting for people. So, okay, so we'll stay tuned. That one study is entering phase two, and then hopefully we'll get more and more data. Which means, of course, when we talk about phases, I also ask just to say what stage is it in, so we know maybe how far off are we from seeing them in clinics. So that's going to take some time, right? So we're not. I mean, how long? I guess when people are like hearing about phases in clinical trials, we don't have a crystal ball, and it's different because it's about the FDA and when it approves gives its approval. But generally speaking, how can we think of it?
So, in general, from the moment a scientist develops a drug in his or her lab, it takes usually a decade until that drug is in the hands of patients.
Right.
Now, it can be more or less time depending upon what drugs are available, what the state of the world is, what other options patients have. So, usually we go through phase one, then two, then three. Phase one is purely finding a dose, but the primary endpoint is safety. We bring up the dose of a drug, usually in a 3 by 3 design, until people have what we call a dose limiting toxicity, and the dose below that is the MTD, the maximum tolerated dose. Then we go on to phase two, and phase two is about treating more people at that dose and really figuring out the nuts and bolts of at that dose. What are the problems? How good is it? The whole 9 yards. And then phase three is saying whatever the standard is, we're going to compare this drug to the standard. So if there's no standard of care, it's that drug versus placebo. Well, in myeloma, we have standards almost everywhere. So, and the same is true for other cancers. So nowadays, there are very few drug versus placebo trials because you can't knowingly give people suboptimal care. So nowadays, what we normally do in our phase three studies for myeloma is give a standard therapy versus a standard therapy plus the new therapy. But not all drugs need a phase three for approval. Some approvals have come across from more extensive phase two studies, and we saw that with both the CAR T and with selinexor and with a few other drugs, that if you have a robust phase two, that may be enough for the FDA to say, let's not wait around, the data is clear cut, let's approve the drug.
Right. I love that you laid that all out. And sometimes too, there's an accelerated approval if there's an unmet need. There's not a drug out there already or a medication for a particular population, right?
So those are there, but there are the accelerated approvals come with caveats. They come with little asterisks. So, for example, selinexor was approved by the FDA in July of 2019 with an asterisk saying accelerated approval, but if the phase three study doesn't read out positively, we're going to take it back. In December of 2020, that phase three read out positive, so it got a full approval. However, there are several drugs that got accelerated approval that were taken off the market, including panobinostat or Faradac that was approved back in 2015 with an accelerated approval. The FDA felt that it had not fulfilled all of the subsequent landmarks, and it was taken off the market a few weeks ago.
Okay, thank you, Dr. Richter. So that was Regeneron 5458. So you talked about the different four, and it's very clear. One of them, so BCMA, another one is GPRC 5D. It's like I'm reading
Yes.
the optometrist, like at the optometrist place, and it's like, read out the thing. Can you talk about the latest update with that one?
Sure. So GPRC5D is another marker that's on all myeloma cells. And there was a couple of really interesting studies. One of them is using a bispecific called talquetamab, which is coming from Janssen and Janssen, or Janssen, which is Johnson and Johnson, a very efficacious drug, also with response rates that are in the 70 to 80% range. Also now looking to sub-Q administration, which has been amazing. And interestingly enough, we saw the first data presented from our colleagues over at Sloan Kettering about a GPRC5D targeted CAR T cell therapy. So the data is really, really early for that. Um, but we're very excited because now we're looking at BCMA therapies after you've progressed on those three other classes. Well, what happens when you progress on a BCMA therapy? We already need the next generation, and that's where the GPRC5D agents are going to sit for the moment. At some point, they may move further up, but talquetamab has been a highly effective drug, already starting to look at combination studies with talquetamab plus daratumumab. And talquetamab has that same CRS risk, but the other risk happens to be wherever that target is expressed. Other than the myeloma cells, you have to worry about side effects. So BCMA is expressed on some immune cells. So another side effect of BCMA targets is infections. But GPRC5D is also expressed on the skin on your hands and the lining of your GI tract. So the two other side effects are a bit of a rash on the hands and what we call dysgeusia, a change in your taste. We have a variety of strategies to mitigate this using emollients, like things like utterly smooth on the hands to help. And sour candies, lemon juice, or biotin washes, things to help the taste. But these are things we need to look out for as we treat more and more patients.
So these rashes, is it like itchy rashes?
We call it a desquamating rash. So the skin kind of peels off. There's an older drug called Xeloda, which is used for some GI cancers like colon cancer that used to cause a similar thing where your hands just kind of, the skin kind of peels off. It doesn't necessarily hurt. It just It's kind of annoying and it feels weird. But if you really use the emollients and uh, lubrication, it really does help quite a bit.
Okay, wonderful. And how much more time are we talking about in terms of having to study this before people are like, oh, talquetamab, I can access that?
So the bispecifics are getting really exciting. The first FDA approval is probably going to come in the fourth quarter of 2022 with another BCMA targeted drug called teclistamab. Talquetamab and some of the other targets are probably not going to be far behind, but we're probably looking at early 2023 for the rest of them to catch up. But crossing fingers that we'll have our first one, teclistamab, in late 2022.
Perfect. Thank you. It's great. Just, again, you don't have the perfect, answer. Who does? We don't know when this is going to, hit the market, so to speak. But I do like that you, give an idea of when we're talking about. I forgot to ask you with the bispecifics, and I want to make clear: is it different for the different kinds of bispecifics? How often people are having to go in for these IV infusions, and what that regimen looks like?
Absolutely. So this is part of our learning of how to do this. Right now, some of them are given once a week and you stay on once a week. A lot of them start off once a week to get the dose level up because you initially have to up titrate the dose. If you give the full dose on the first day, your immune system will become overwhelmed. So we have a ramp up period where you'll get 5 milligrams on day one. The next week you'll get 25, and the week after 50 or 200 to kind of set up your immune system to not overwhelm it. And then many of these will eventually go to every 2 week or every 3 week, and a couple of them were started to give every 4 weeks. Now, again, right now, these are all under clinical trials, so we're bound by the laws of the protocol. We can't deviate. If you deviate too much, you cause trouble, and they say, no, this is not according to how it works. But once a drug is approved, you have a little more freedom of how you can do it. So if we have these drugs approved and a patient says they're doing great on every 3 weeks and they ask, can they come every four? You can talk about the risks and benefits, but a lot more flexibility then.
I hope not to get too in the weeds here, but I was wondering if you're talking about some that'll be given weekly, some biweekly, some every month, or once every 4 weeks, excuse me. And I'm sure some of it is patient dependent, but largely speaking, if one, you have two options and they're about the same in terms of efficacy, but one, like what would make someone want to take the every 1 or 2 weeks versus the every 4 weeks?
A lot of this will have to do with the language and way the FDA approves it. So, for example, if two drugs are virtually the same, one is weekly and one is every 3 weeks, but this one is approved in combination with another drug, or this one has a slightly different side effect profile. So, for example, the talquetamab and teclistamab, both amazing drugs, probably not too different in terms of efficacy, but this one causes the rash and the change in taste, so we may go that direction. It also ultimately will determine what you've had before. So if you haven't had a BCMA therapy, maybe you'll get a BCMA bispecific. If you already had a BCMA CAR T, maybe we'll give you a different target for a bispecific. So a lot of this is really going to get granular once they get approved.
So just to be clear, high level, if they have the same target, they should be the same frequency in terms of administration, or no?
No,
Okay.
because it really depends upon that's only kind of the action part of the molecule, but there's other parts of the molecule as well. So in the BCMA bispecific world, there are a litany of drugs from drugs like teclistamab, Regeneron 5458, Regeneron 5459, AMG 701, elranatamab, Tineo and they're all BCMA bispecifics. But some can be given once a week and some once every 4 weeks. And again, part of this is as we test the drug in early phases, what does that pattern look like as we bring up the dose? Because antibody drugs are not just more drug equals more activity. The best way to think about antibody drugs is like a lock and a key. All the cancer cells have locks, and the drug is the key. And once every lock has a key in it, or what we call 100% receptor occupancy, dumping more keys in the system may not do anything because all the locks have a key in it. So it's really all about finding the sweet spot. Goldilocks. What is too much? What is too little? And what is that sweet spot?
Okay, thank you for bringing us through that. Um, again, I like more animations in my head while you're talking. So another one, so the FCRH5, so cevostamab.
Mhm.
Talk about that one in terms of what that update looks like.
So cevostamab is another great drug we've been using. It's an FCRH5 CD3. And again, response rates, depending upon which subgroup, around 60 to 80%, which have been amazing. What the really great thing about cevostamab and talquetamab is that BCMA therapies are poised to take over the myeloma world. We already have Blenrep approved and Abecma approved. So we already have two BCMA therapies. They're working their way up to earlier relapses, and same thing with all of the BCMA bispecifics in trials. But we're really looking to say, all right, well, if in a couple years a BCMA therapy is going to be part of your early treatment, we want to set you up for a non-BCMA therapy later on. And that's why talquetamab and cevostamab are becoming so exciting, is that we can go from one target to another and hopefully maintain maximal efficacy.
Wonderful. And I know in that study, and you talked about step up because talking about dosing, but in terms of relaying it to patients again, what this means for them, it's really just about figuring out, yeah, what's the right amount to give and how and when.
Mhm. Usually for the bispecifics, the way all of them, cevostamab, talquetamab, teclistamab, right now we're still trying to figure out the who, what, when, why, how of cytokine release. So the way we're doing these trials is cycle one, day one, your first dose of the drug, you get your lower dose as part of the step up. After you get that dose, you're admitted to the hospital for between 24 and 72 hours, depending upon your disease and the trial, and then you go home. The next week, which is cycle one, day 8, we either have a second step up dose, so not quite full dose, or we're ready to get to the full dose, depending upon the trial. You're admitted again for another 24 hours to make sure you don't have any overwhelming CRS. And then by the third week, almost all these trials, you're outpatient. You can continue. And the wonderful thing about bispecifics is that in the United States, about 70 to 80% of myeloma is treated in the community. And where CAR Ts are wonderful things, CAR Ts are always going to be in the big academic centers where they do things like transplants. Bispecifics are off the shelf. You don't have to manufacture anything. If you show up with bad disease today, I can give it to you. And it can be given in the community, which means it's poised to be a more ubiquitous treatment for as many patients as possible.
That is huge. I remember you had mentioned that once before, right? And I really appreciate you bringing up the number about the 70 to 80%, the vast majority of patients in myeloma being treated in community settings, because access is such a big issue. And so that's going to be a huge plus for people.
The other big question was, can you sequence BCMA therapy? So if you got a BCMA CAR T, can you then get a BCMA bispecific? And we used to think, well, no, you've kind of used that up. Well, some of the data this year's ASH is no, you can sequence two BCMA therapies, a CAR T and a bispecific, or the other way around, and still get great outcomes. We don't know yet will the outcomes be even better if you bring in a different target like FCRH5 or GPRC5D. But either way, there'll become a time in 2022 where we don't yet have GPRC bispecific talquetamab, we don't have FCRH5 cevostamab, but we'll have two CAR Ts that target BCMA and at least one bispecific. And even in those early days, we'll know that if you got one, you can get the other after.
Oh, so much learning happening, which is awesome. I mean, which is wonderful news. So okay, so high level as we wrap up, I do want to hit cell mods really quickly, but as we wrap up bispecifics, the takeaways are the earliest could be end of next year, again, give or take some months. But the other ones should follow shortly after. That the response rates have been incredible, 70 to 80%, which is huge. I mean, 60 to 80, 70, and that the side effects, or what you call safety side effects, seem not to be. I mean, you've got the CRS, the cytokine release syndrome, and outside of that, with some of these rashes you're talking about, nothing super worrisome.
No, the only thing is when, right now everyone's immune system is fighting cancer and infections. And when you kind of tell the majority of your immune system to fight cancer, it's like you have the army and you're fighting multiple fronts. And if you take away your Air Force and Navy and now they're fighting over here, you may have some issues with the battles on the other side. So we are seeing some more infections with these complications. BCMA therapies are now known to reduce people's responses to COVID vaccination and antibody production. So we're actually embarking on a number of mitigation protocols and strategies to help protect people from infections while they're getting such great responses.
Thank you for addressing that actually, because COVID is obviously so top of mind and continues to be.